those, check those out. And yeah, any questions about anything that's coming up? Anybody bringing their parents on Friday to class? Yeah, they can come to class if they want. We got a couple extra seats. Yeah. It's always fun to have some parents in here. So we usually get a few, but it's up to you. Is anybody afraid to bring them because they're gonna cause a scene? All right, hold on, guys, hold on. All right, everybody's talking about what would happen if they brought their parents and the embarrassing things they would do. Is that what you're talking about? Okay, go ahead. What were you gonna say? Sorry, hold on. I still can't hear your question. We come back together, guys? Thanks. Thank you. Go ahead. That's not on exam 3, correct? Yep. Yep. TBL. So the stuff we cover on Friday will be the last material for exam 3. Okay. Any other questions about anything? Is anybody going to bring their parents to class? Raise your hands. Not sure. It's tougher at Liberty Station now, probably, but okay. Well, you're welcome to if you want to. All right. Okay, so we're going to dive into some specific joints a little bit today. Talk about some of the specific injuries that we would see in these joints. So yeah, let's start out with this question. We're gonna start with the shoulder. So and we're going to talk about these as joint complexes. Okay, and the shoulder joint complex contains multiple articulations. And so yeah, what do you think about this one? Go ahead, talk to the people around you. Vote on your clickers when you're ready. Start. All right, we got 40 of you. Go ahead and send it in. All right, about 10 more seconds. A couple more of you need to send it in. Okay, anybody else? Is that it? Got 65 responses. Probably pretty close. We got a normal distribution of answers, which means we're all over the place, and that's okay. We haven't talked about it yet, just kind of something to think about here. So which joint connects the shoulder complex to the axial skeleton via a bony articulation? It's actually this one right here, this little, pencil's not working. You guys can't see what I'm circling. Get that to connect. It's C, sternoclavicular joint. Which feels a little weird, right? Because it's like this big complex, our whole upper extremity. This little tiny joint right here is really the only bony articulation that connects it back to our sternum. There we go. Back to our axial skeleton. Okay, so we'll talk about all these joints here in a second. But this one is kind of, it's not really a bony articulation, right? Definitely our scapula interacts with our back, but there's no actual like joints there, right? It's just muscles attaching and kind of holding it down, but there's really no actual bony articulations there. Okay, so with each of these joints that we talk about today, the thing you want to keep in mind is which bones are included in this joint complex. Okay, so that's number one, which bones, which bony articulations are included in this joint complex. Okay, so and most of these complexes we'll talk about have more than one, right? And then which movements do those joints do, and then we'll talk about some specific ligaments or cartilage structures within each of those. So you want to know those, and then we'll kind of talk about some injuries associated with each one. Okay, so let's talk about the bones of the shoulder first. So there's 4. There's the scapula, the humerus, the sternum, and the clavicle. Those are all the bones included in this shoulder joint complex. Okay. The scapula is kind of strange because it's almost floating, right? There's really no, like that's what we are just talking about. There's really no true bony articulation that just kind of anchors it to your thorax. It's floating on your back kind of. And then you have this little clavicle that connects it to your sternum, but there's really no strong bone-to-bone connection there. The clavicle is known as our most broken bone in the body, the most commonly fractured bone in the body is the clavicle. How many people have broken their collarbone before? Yeah, that's quite a few in class. Yeah. Anybody have to have surgery on it? You did, Tyler? Yeah. Did you get a plate in there, or what happened?
Yeah, they put
Plate. Okay. Yeah. Does it show up on X-rays now? Plate. Yeah, that's cool. Have you ever seen Lance Armstrong's X-ray? Has anybody seen that? Yeah, he broke his multiple times, but they put like a carbon fiber one in there, and it has like the emblem of like some bike company on there. Like so in the X-ray you can actually like see the bike company. I can't remember what it is, but it's funny. But yeah, pretty common one. Was yours sticking like way up when you broke it, or not too bad? Yeah. Okay. Yeah. A lot of times they don't do surgery unless it's really out of place. A lot of times they just let it kind of heal back down. But if it must have been somewhat out of place. But yeah. Okay. So yeah, those are the bones. The joints or the bony articulations would be number one, the glenohumeral joint. That's what we think of when we think of the shoulder, right? That's where the humerus comes and meets up with the scapula. Okay. Then we've got the sternoclavicular joint, also known as the SC joint. Okay, so the sternum and the clavicle, that's what we were just talking about. That's the one right in here. Okay. Then we've got the AC joint, or the acromioclavicular joint. And then kind of this, like we've been talking about, this kind of not really an bony articulation, but where the scapula goes up and down the thorax when the scapula moves up and down. Okay. Let's palpate those, the SC joint and the AC joint, so you can kind of get a feel for what that is. So best way to do is just find your clavicle right there in the middle. Okay. Find your collarbone. And then we're going to walk out lateral first with your fingers. So just kind of walk out really slowly, and you'll kind of feel a place where it's probably easier with your other hand. Yeah, you'll feel a place where it kind of lifts up a little bit, and then it drops into a little joint cavity. Okay, so it kind of lifts up, and then there's like a soft spot where the joint cavity is. And if you press in that, it's kind of tender. You'll probably notice it. Yeah, so you should find like a little bit of like a little canyon right there, kind of between your acromion and between your clavicle. That's the AC joint. And then if you abduct your shoulder a little bit, you might feel a little bit of crunching in there, at least your clavicle kind of moving around. That joint has to move when you abduct and when you move your shoulder at all. And then let's walk the other direction all the way back towards your sternum. Okay, get all the way back towards your sternum. And then this one, again, the end of the clavicle kind of lifts up a little bit, and then it drops down into that little canyon. And this one's pretty tender most of the time. If you feel that little canyon, then you kind of push down in there. It's kind of tender. And then again, abduct your shoulder, and your clavicle's going like this, right? So your SC joint is allowing that to happen. So you feel that little thing in your SC joint. And your SC joint has a little meniscus in it, just like your knee. So there's a little piece of cartilage there on the sternum side that's kind of helping to deepen that joint a little bit. But that's the kind of the cool thing when we start talking about joints and muscles, is you have all the parts that you're studying, right? And you can feel them, okay? And so that's actually really helpful when we start learning muscles, is don't just think about it as this kind of intangible concept. It's right there. See if you can find it on your own body, and it actually helps you really a lot to learn this stuff if you feel it on yourself, right? Okay, so those are the joints there. Let's talk about each of those a little bit. So the sternoclavicular joint, SC joint, this is the one we were just talking about. So it's right here. So the articulation between the sternum and the clavicle. Again, like we just said, the only bony attachment of the shoulder to the axial skeleton. Okay, so known as the SC joint. SC joint injuries are pretty painful, actually. If you sprain this joint, or if you damage that cartilage in there, it's a painful injury, and it can catch in there just like any meniscus type injury could, and it can be pretty painful. Not very common to damage that joint, but it can happen. Much more common is to damage this joint, the AC joint, and this is the articulation out here between the clavicle and the acromion process of the scapula. Okay, also known as the AC joint. And so when somebody says, I separated my shoulder, that means an AC joint sprain. Okay, so a separated shoulder means that we've sprained the ligaments in here holding the clavicle and the AC joint. and the clavicle pops up like this, and you'll see a big bump in the end of their shoulder there. And that can be mistaken for a clavicle fracture. It's most time it's really hard to tell if you're just looking at it, whether that's a shoulder separation or a clavicle fracture. Okay? A lot of times the clavicle fracture will be more in the middle of the clavicle and the separation will be out here, but sometimes it's hard to tell that for sure. You don't need to know the names of these ligaments, but when you do separate your shoulder, a lot of times you sprain these ligaments, which lets the clavicle move upwards. Okay, so the most common way to do that would be to land right on top of your acromion, like this guy. Right. So if you land right on top of your acromion, that moves your scapula downwards and doesn't take the clavicle with it, right? And so if the clavicle just stays up, that's what happens. The clavicle goes up, that's a separated shoulder. And so it would look something like that, right? So you can trace his clavicle all the way to right there, but his acromion's down here, right? They're supposed to be attached, right? And so that's a separated shoulder. Okay, you can see what the x-ray looks like. Yeah. Yeah, and so I think, yeah, did I put Soren? Yeah, this is actually, is another family x-ray here. This is my son Christian, the middle one. He was jumping around on our couch and jumped off the back and landed on his shoulder, and he landed right on his acromion. And it was really hard. I actually thought he just separated his shoulder. I wasn't sure if it was a clavicular fracture or separated shoulder, but his was a clavicle fracture, which you can see right there. It's not the best picture of the x-ray. It's hard to take a picture of the little computer screen sometimes, but yeah, his AC joint is actually intact, right? So he had a big bump there too, but the bump was more in the middle, right, instead of out on the end. So that's where it can be kind of tricky to differentiate between the two without an x-ray. Has anybody separated the shoulder in here? Anybody done that? No? Okay, yeah. Okay, all right. And then the big joint of the shoulder joint complex is the glenohumeral joint, right? And this is the articulation between the humerus and the glenoid fossa or the glenoid cavity. Okay, this is the most highly mobile joint in the body, right? So greatest range of motion. That's what the ROM is for, range of motion of any joint in the body. Okay, so it's designed for lots and lots of mobility, right? This thing we talked about last time, this golf ball on the tee, right? So the big humeral head fits into that small little concave surface of the glenoid fossa. Okay, so the bony support is really lacking here, right? We don't have a lot of we don't have a lot of structural support like we talked about last time. There are some ligaments, but they're pretty weak and loose, right? And which is what we need to be able to move our shoulder all over, but it also makes this joint highly susceptible to being dislocated. Okay, so when somebody says they dislocate their shoulder, it's that humeral head coming out of the socket. When somebody says they separates their shoulder, it's that AC joint getting sprained. Okay, so the glenoid fossa is only about a quarter of the size of the humeral head, and that's where it gets that idea of the golf ball on the tee. Okay, so some of the shoulder ligaments, and I do want you to know these couple ligaments here. Okay, so there's two that I want you to know, the coracohumeral ligament. Okay, and the nice thing about most ligaments is that they're named after the two bony structures that they connect to. Okay, and this is no exception to that. So the coraco, what bony structure do you think that's connecting to? Yeah, coracoid process. Okay, and then the humerus, obviously. So coracohumeral. Okay, so we can see that right here. So coming from this coracoid process, coming over here to the humerus. Okay, so this resists movement anteriorly and superiorly, and you can kind of envision that from the direction of that ligament is going, right? If we tried to move the humeral head up and then a little bit forward, it would pretty much tighten that ligament exactly, right? And that's what ligaments do. They're always going to be in a certain line of pull to limit a certain range of motion. Okay, and then the glenohumeral ligament is a big ligament. It has 3 different sections to it, but it's primarily going to resist anterior movement of the shoulder. Okay, or the anterior movement of the humerus, really, that it keeps that humeral head from popping out anteriorly. Okay, but that is the most common way to dislocate your shoulder, is an anterior dislocation when that humeral head pops out anteriorly. Okay, and again, because that ligament's really loose and really weak. All right, how many people have dislocated their shoulder? Got a couple there, yeah, okay. James, did you pop it right back in then? Somebody help you pop it back in, or have you done it a bunch of times? A couple of times. You did it yourself. You popped it back in yourself? Or? It pops back in yourself. Okay. Yeah, kind of pops down. How about you, Ashley? Okay, when they sat you up. Okay, nice. That's good. How about you, Trevor? Yeah. Yeah. Definitely. Yeah. 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 So I don't know what the percentage of people is. It's not huge, but yeah, some people just don't have it at all. So those people would be definitely more susceptible to dislocating their shoulder. Yeah. Okay. Any other questions about that? Okay, so that's the shoulder as far as ligamentous support, and then musculotendinous support. We talked about this already, that the biceps brachii is a really important stabilizer of the shoulder. Okay, and so it's so the biceps has two heads. That's why it's called bi, right? And it has two different tendons that come up. One goes right to the short head, goes right to that coracoid process, but then the long head goes through that intertubercular groove, right? And then it goes up over the humeral head and connects to the superior part of the labrum, which is right there on the glenoid fossa. Okay, and so when you contract your biceps, that actually kind of squeezes your humeral head into the glenoid fossa a little bit and holds it in place. So that one's really helpful. So the upper rim of the glenoid fossa pulls the humerus against the glenoid fossa. So that one's definitely helpful for stabilizing your shoulder. Okay, but then we've got the rotator cuff too, right? These four muscles really just designed to pull the humeral head into the glenoid fossa. That's really what they do. They're not big movers of the shoulder, although they each do have movement functions, but their big job is really just pulling that humeral head in. Okay, so they insert on the anterior / superior aspect of the humerus. Okay, so we see most of the insertions here. Okay, and they come around this way a little bit. Okay, so they kind of make a cuff around the humeral head. When they all contract together, they all pull that humeral head, just pull it right in towards the glenoid fossa, and that's really the importance of those. Okay, so they pull or cuff the humerus into the glenoid fossa, but they're also important decelerators of shoulder motion, and we'll talk more about those, what that means when we start talking about muscles. Okay, and there's four of them, and you can use the acronym SITS to help you remember, just SITS. Okay, so we've got subscapularis. Yeah, really, it should go the other way. It should start up here: supraspinatus, infraspinatus, teres minor, and then subscapularis. Okay, so 1, 2, 3, 4. And you'll have to remember those muscles and their exact actions when we get to the shoulder muscles. But for now, you can just kind of know of them as the rotator cuff and what they do in general with these functions here. Okay. All right. So take a second and talk with the people on your team about this question, and then by looking at that image there, you should be able to answer this question: which of the rotator cuff muscles is on the anterior side of the scapula? All right. Got about 5 more of you. Go ahead and send it in. Give you about 5 more seconds. All right, so what you guys said, good. So 100% of you are saying C, subscapularis, right? And that actually means it's like underneath the scapula. It's between your scapula and your thorax, but it's really on your scapula, but it just kind of sits underneath it, okay? All right. Okay, so then this labrum, we've talked about this a little bit before. The definition of this is this lip of fibrocartilage that is surrounding the joint. Okay, so we can see it right out there. This is actually a little piece of that biceps brachii long head tendon, right? That would come up and attach right there. We can see that. You can see how it just kind of weaves right into the labrum. And so actually somewhat of a common shoulder injury is called a slap lesion. Okay, and that slap lesion, what that means is that biceps tendon actually has ripped off its attachment and it pulls part of the labrum with it. So you get a labral tear as well as that biceps brachii tear all together. Okay. So this increases the depth quite a bit. And like I mentioned before, increases the contact area between the humeral head and the glenoid by about 75%. So super, super helpful as far as giving us more stabilization in the shoulder, making a shoulder joint that's not very stable, just a little bit more stable. Okay. All right, so let's do this clicker question here. Make sure we're all tracking. Feel free to talk to each other, make sure you're on the same page. Just trying out your shoulder, yeah. Yeah.
For the labrum, you say it's a lipofibrocartilage surrounding the joint. Is that like on the surface of the joint, or is
It's
it
really
like
on. It's really on the glenoid fossa, so it's more connected to the scapula. So the humeral head kind of sits
so it's
in the
like-
middle of it.
So it's on top of the bone itself.
It's actually, yeah, it's connected to the bone. The joint capsule would be outside of it though.
Okay.
So it's kind of like really in the joint capsule, but it's just on the very outer edge of it. Yeah. All right, go ahead and send that in if you haven't yet. A few more of you can send it in. All right. Yeah, so 91% of you are saying D. So the glenohumeral joint is a shoulder dislocation, whereas the acromioclavicular or AC is a shoulder separation. Okay. Any other questions about the shoulder? Okay. All right, so let's talk about the elbow a little bit. So the elbow is made up of two separate joints. Okay, first of all, we have the humerus and the ulna articulation, right? That's really the one we think of when we think of the elbow. This is the one that's the hinge joint, right? It's one that allows us to do flexion and extension of the elbow. Okay, so extension is when we make our elbow straight, flexion is when we bring it up. Okay, but then we have this other little one, right? This radius ulna joint right there. And that's what allows for, again, supination when we're putting our palm up, and then pronation when we're putting our palm down. This is a pivot joint. Okay. This little interaction as well is also involved. The radius capitulum is also part of that thing that complex that moves when we do the supination and pronation. But it's more so the head of the radius and that ulnar or that radial notch that are doing most of the interaction for pronation and supination. Okay. Okay, so elbow ligaments, similar to the knee, the elbow has collateral ligaments. Okay, we name these not by medial or lateral like we do in the knee, but we name them by the forearm bone that they're closest to. Okay, so we have the ulnar collateral ligament or the UCL. Okay, and this protects against a movement called valgus. Okay, and I showed you this last class when I was standing up on the table. Luckily, Alicia wasn't here because I was able to stand right there where you were. But yeah, and so that was when my knee bowed in. Remember when my knee went in like that? It's the same thing with the elbow. If someone was to push my elbow from this side and the middle of the joint opened up, that's valgus. Okay, so if you put your arm down and someone hits you from the side and that opens up the medial side of your elbow, that's valgus. Okay, so that UCL protects against that, right? And so, yeah, we'll talk about the injury in a second. But then we have the RCL or the radial collateral ligament on the other side. and that one protects against varus. So varus is just the exact opposite. If your elbow's down and somebody hits you around the medial side and it opens up that lateral portion, that's varus. Okay, so if you think about it like this, if you think about these are my two bones coming together for my elbow. This will, let's say this is my right elbow. Somebody hits me from over here, it opens up like this, and this is my right elbow. What's that, varus or valgus? Valgus, good. Yeah, that's valgus, and that would put stress on the UCL. Okay. So again, if this is my right elbow and you have an anterior view of it, and somebody hits me from this side, opens up that side of the joint, then that's varus. Okay, and that would put stress on the RCL or the radiocollateral ligament. Okay. So really common injury these days in pitchers and baseball is what? Who knows? What's it called when you sprain one of those ligaments? Sure, we got one baseball player in here at least, right? What's it called when they do this too much? Tommy John's, right? When somebody has Tommy John surgery, right? That's damage to their UCL. That's what it is. Okay, so pitchers are constantly doing this, right? So they throw and they bring it forward. When they're bringing it forward like that, they get major valgus-like stress on their elbows, right? And if you do that just hundreds and thousands of times, throwing over and over again at very high velocities, then it puts stress on this ulnar collateral ligament, and it eventually can tear. Okay, and so what Tommy John surgery does is it takes this little tendon in your forearm, okay, called the palmaris longus tendon, and you can find it in your own forearm if you do something kind of like this. So kind of put your hands like that, like you're kind of like threatening to, like, I don't know, scratch somebody like a cat or something like this. Okay, and then kind of flex your wrist a little bit, and you should see a prominent tendon that pops up in your wrist. Okay, look at your partner, see if you can find that little tendon that pops up right there. There's kind of one thin one that pops up.
Oh, look at that.
Yeah, so really do it like that, like squeeze your palm like that. That's really what the palmaris longus does. It's all about tightening your palm. Don't hurt yourself. Doesn't show. Well, you might not have it. 20% of people don't have it. Actually, that's it. Yeah. Yeah. How many people think they can't find it on themselves? Yeah. So it's about 20% of the population doesn't have this muscle anymore. Okay. So there's a chance you don't have it. Okay. But it's this little tiny muscle. We'll see it when we open up the cadavers. The muscle belly is like this big, literally, it's tiny. Okay, very, very small little muscle. And then it goes down to this long tendon, and it actually just attaches to like the connective tissue in your palm. So its job is just to tighten up the connective tissue in your palm. It doesn't actually produce wrist movement or anything like that. That's why it's really, the movement is like doing like this, like squeezing in your hand like that. So what they do with Tommy John surgery, and surgeons must have thought at some point, this is tiny little muscle belly, it can't be doing much. Let's see if we can use it for a ligament instead. So that's literally what they do. They open it up, they cut out that palmaris longus tendon, and then they drill holes in the medial side of the humerus right here, okay? And then drill holes in the medial side of the ulna, and then they weave that tendon through in a figure-8 pattern, staple it down on both sides or screw it down on both sides, and that's the new UCL ligament. And that's what Tommy John surgery is. And they have to get it the exact right tightness. There's many Major League Baseball pitchers that come back and they throw a couple miles an hour faster after they've had Tommy John surgery than they did before. Part of that is maybe they put it a little bit tighter than the previous one was, and so they can get a little bit more velocity out of it. But that's what it is. So this is called palmaris longus. And we'll see palmaris longus in the cat, and we'll see palmaris longus in the human cadaver as well, coming up soon. Okay, any questions about those? All right. Okay, so next joint, we'll talk about the hip joint, okay? This is a ball and socket joint, as we've talked about before. Pretty large range of motion. Again, it's much, much more stable than the shoulder, even though it's also a ball and socket joint. What was one of the biggest reasons for that? Guys remember? Of those different categories of support, we had structural, we had musculotendinous, ligamentous, and cartilage. Which one really stands out with the hip? Structural and yeah, so structural for sure, because we got this big deep socket. So that's probably the most important part. But then secondly, we got some really strong ligaments in the hip too. Okay. So deep socket, strong ligaments. And then even though the socket's already so deep, it also has a labrum too to deepen it even more. So we've got kind of three factors that really give it a lot of support. Okay, the one ligament I want you to know for this one is called iliofemoral ligament. Okay, so it goes from the ilium to the femur. Right, it's just kind of this anterior ligament here, kind of has two different bands to it. Strongest ligament in the body. I talked about this one before. It takes over 700 pounds to damage it. Okay, so lots and lots of tensile strength. If you ever see people that kind of like stand like this, kind of like like rock their pelvis forward and their hip kind of comes forward, that's kind of you're putting stress right on that iliofemoral ligament when you do that. When you can kind of picture your femur kind of rocking forward, that's really what that is. Okay. All right. So that's the hip. Won't talk too much about hip injuries. I will, I guess, tell one story about the hip that's kind of fun. When I was working for the Chargers, our team doctor was just kind of super gung-ho and super confident. And most people won't relocate a hip injury on the field because there's so many arteries and nerves and veins that just travel right next to the hip, like big ones too, like the sciatic nerve and the femoral artery. And so we were playing the Vikings, and there was a guy on the team that dislocated his hip on the field. Which it's a super painful thing, and you definitely can't move at all when you have a dislocated hip. Their team doctor was not willing to touch it, but our doctor was like, sure, I'll put it back in, no problem. He went out there and literally kind of knew how to do it just right. And like, you just have to kind of lift it up over that labrum and pop it back in. And the guy was very happy that he did it because you feel immediately better, but it's also very risky, right? If you happen to pinch the femoral artery, they could lose their leg, right? If you pinch the sciatic nerve, that could be major nerve damage for life. But he didn't have any of that. The doctor was confident and made it happen. So it was pretty intense, but yeah. So don't try that at home unless you're trained to do that. But yeah. So okay, so let's talk about the knee a little bit. The knee is kind of considered the most complex and the largest joint in the body. Okay, it's not truly a hinge joint because it doesn't just allow for flexion and extension. It also allows for a little bit of rotation. Okay, so it's known as like a modified hinge joint, right? And you guys can experience that rotation part. Maybe you've never noticed it, but you're all in the perfect position for it. If your knee's at about 90 degrees, obviously extension is just kicking out, flexion is pulling back. But if your knee's at about 90 degrees, just take your foot and move it in like that. Okay, and if you kind of grab like right at the top of your tibia when you're doing that, you'll feel your tibia kind of moving like this. Right, your tibia kind of rotates medially a little bit, and then it rotates laterally a little bit, and that's that knee rotation. Right, it's not a motion that we think of a lot, but it's definitely an important motion for full function of the knee. Okay, so four bones of the knee joint complex, obviously the tibia, the fibula, the patella, and the femur. Okay, the fibula is kind of this sideline bone that's not like directly right in the main joint of the knee, but when we do that rotational movement, this joint moves a little bit. Okay, try it again. Do that same thing, but put your hand on your fibula this time instead on the lateral side of your knee, and do that rotational thing, and you will feel a little bit of fibular movement up there. It's not much. It doesn't move a whole lot, but it does kind of slide a little bit in there when you do that. Okay, so there's three primary joints in the knee: the femur and the tibia. That's the big one, right here. The fibula in the tibia, that's this one. It's a little bit of sliding that happens there. All right, but then also the way that the patella slides over the femur, right? And so that's right here. When we flex and extend our knee, our patella is sliding over the top of our femur. Okay, so three different kind of bony articulations there. And then we've got the cartilage that we've talked about, the medial and lateral menisci. Okay, there's two of them. One on the medial side, one on the lateral side. Just like any of those cartilage rims, they help to deepen the articulation, help with some shock absorption, and they definitely stabilize against lateral and medial motion. Okay, because like we talked about before, the top of the tibia is pretty flat, right? And then we got these big round femoral condyles going down into them. So these really help to make the top of the tibia a little bit more concave, so it can receive that convex surface of the femur a little bit better. Okay. Any questions on any of that? So we got 3 joints, 4 bones in the knee. Okay, go ahead. Yeah, there'll be a better picture of it here in a second, but yeah, the lateral one will be over here, the medial one's on the other side, but we'll see another picture in a second. Yeah. Go ahead, Lisa. Yeah, so I mean, it's pretty much like with the knee, with the tibia, we've like pictured this being the tibial plateau where those femoral condyles are going to come down. It's pretty much flat and maybe just has a little bit of a rim on each side. But when we add, instead of, so pretty much, let's say this is without the cartilage. If we put a meniscus there, then we're kind of just like doing that, right? So we have like a little bit of an extra lip on both sides. And so then when that femur comes down in, it has like a little bit of a bumper that it can't quite go over, right? And that's pretty much what it is. Yeah. Yeah. Okay, other questions on that? Okay, so ligaments of the knee that I want you to know. There are some ligaments that hold the patella down that you can see in this image. I have them named there, but you don't have to know them. That's why they're crossed out. Okay, but we do have what's called the patellar ligament, but it's really acts more like a tendon. Okay, that's connecting the patella to the kneecap. Okay, actually, let's do it this way. Why don't you guys go ahead and label those yourselves by knowing what you know, and then answer that question there with your clickers, which one of those would be the MCL. Go ahead and talk with the people next to you. All right, go ahead and send in that answer on your clicker when you're ready. All right, about 5 more seconds. Need a few more of you to send it in. Okay, so we got everybody. All right, so most of you are saying D is the medial collateral ligament. Okay, that's correct. How'd you know that's the medial side? What's the dead giveaway? Fibula, yeah, absolutely. Fibula is always on the lateral side for sure. Okay, some of you put C. C is one of those patellar retinacula. Okay, so C and B are both these ligaments you don't need to know, but they're just in this image. So I thought I'd tell you what they are. They help hold the patella down and make sure it doesn't slide off. Okay, if you've dislocated your patella, then you've most likely sprained one of these along the way. But yeah, then we've got the MCL over here, right? And then the LCL is A. Okay. Yeah, and so which one would present or prevent valgus? MCL, right? Yeah, MCL prevents valgus. LCL prevents varus. Okay, and then we've also got the anterior and posterior cruciate ligaments. We'll see some images of them on the next couple slides, but I do want you to be able to identify and know those ones as well. Okay, any questions about this one before we keep going? Go ahead. Which one? E, yes, E. So E is that patellar ligament. And that's really kind of part of the quadriceps muscle structure, really, right? This is really how our quadriceps are connecting to our tibia. But since it goes from bone to bone, it's technically a ligament, even though it really functions more like a tendon, right? Because it's really helping the quads connect to the tibia, but it goes through a bone first. Good question, thank you. Okay, so yeah, LCL, MCL. See this one right here? Which one would he spray in there? Just yell it out. What do you think? MCL. Yep, for sure. So there's valgus kind of pushing in, varus pushing out. Yeah, he probably also tore his ACL with that one too, but definitely his MCL for sure. Probably his meniscus as well. Okay. Yeah, so ACL, PCL. So there's two ways to think about the way that these ligaments work. One would be with the femur stable and the tibia moving. The other would be with the tibia stable and the femur moving, okay? And you just need to kind of wrap your head around both ways. So the ACL prevents the femur from sliding posteriorly on the tibia, okay? Or we could say the tibia from sliding anteriorly on the femur. It's kind of the same thing, right? If you think about it, right? So if my femur's up here, my tibia is down here, okay, the ACL is going to prevent my tibia from coming forward or my femur from coming backwards, but it's kind of the same thing, right? They're tightening the ligament the same way, right? And so that's why, but just do need to be familiar with that, how the wording is different there, okay? And then the PCL is the opposite. We're going like this. It's going to keep the tibia from sliding backwards or the femur from sliding forwards, okay? The easiest way to remember that is the most common way to tear your PCL is in a car accident. When you slide forward and your tibia hits the dashboard or hits the steering wheel and it just slams your tibia backwards, right? That's kind of the if you can remember that picture, and that being the PCL, then that might help you. The PCL prevents posterior translation of the tibia. ACL prevents anterior translation of the tibia. Okay, questions on that? Okay. Yeah, do we have time for that? Maybe we do. Let's do it real quick. Okay. There's a couple really easy special tests you can do that I can show you how to do real quick. Yeah, what would be the best way to do this? Hunter, would you mind, since there's nobody next to you, sitting on your table for a second? Yeah. Okay. So yeah, hop up on your table. Yeah, just like that. Just put your knee out. Perfect. And so what I'll have you guys do in a second, really, a way to test the ACL is to grab the back of the tibia and just slide it forward, okay? And the way to test the PCL is take the tibia and slide it backwards, okay? So what you kind of do is you sit, I'm trying to sit on your foot actually, yeah, thanks. Yeah, so you sit on their foot and you take their tibia and you kind of just slide it forwards. That's called the anterior drawer test. You're pulling on the ACL by doing that, and then you push it backwards and you feel a nice catch there. It shouldn't go too far. That's the PCL. Okay, why don't you guys try that for a second? Have one of you hop up on the table with the person sitting next to you. Try it out. So ACL forward, PCL backwards. Yeah, so pulling nice and hard, kind of pulling her whole, yeah, that's ACL there, and then push it back. That would be PCL, yeah. You hurting each other? Do you feel it kind of catch, or do you kind of move? Yeah, yeah. Guys, so you'll feel it kind of moving there, like stop. So like that's a good, yeah. Yeah.
Then, like, let's say for the ACL, would it like come further?
It comes further, but the bigger deal is what's called the end point. And so the better test is Lockman's test, which is really like maybe you've seen people do it with soccer players, but it's when their legs straighter and you kind of pull it up like this, and when the ACL is there, it pulls up and it stops. You have a nice solid end point, but when it's not there, it kind of just it's kind of mushy, and it's more the muscles catching it instead of the ligament. Yeah. So. All right. Well, it takes a lot of practice to get that exactly down, but maybe you'll kind of remember when you pull that tibia forward, you're testing the ACL. When you're pushing it backwards, you're testing the PCL. And really what you're feeling for is what's called end feel. Okay. And so, because you're not just going to like pull it all the way if their ACL is not there. But when you have a good solid ACL, you'll pull it and you'll feel like a solid catch. It kind of just stops, right? But when the ACL is not there, you pull it forward and it has this kind of mushy feel to it, just kind of keeps coming, but then it kind of stops. That's because the muscles are stopping it instead of the ligament, right? And so that's really what you're looking for with those tests. Yeah. Okay, any questions about any of that? All right. Okay, so knee injuries, ACL sprain, very common. One of the most common orthopedic surgeries done is the ACL reconstruction surgery. It usually involves some valgus as well as rotation of the knee. Okay, it's common to sprain your ACL in a non-contact fashion. Okay, so you're running and you plant and then you turn and go, and then it just falls in valgus wise, but you're rotating at the same time. And then, so it's really common to have these non-contact ACL sprains. It's worse if somebody also hits you from the outside when you're doing that, and then it's much more likely to tear it. But non-contact ACL sprains are common. There's a few different ways to repair it. One of the most common ways is to pull out the middle 1/3 of your patellar tendon. Okay, and they take a little bit of bone from your tibia and a little bit of bone from your patella. And this is where those orthopedic surgeons are like mechanics. They're literally knocking in there with a hammer and chisel, chipping out the little pieces of bone. And they drill a hole in there. Over here, they drill a hole from the outside of your femur, pop it through. They run that through, get the exact right tightness, and then screw it down on both sides, and you've got a new ACL, pretty much. It's also done with hamstring tendon as well. That one doesn't include the bone chunks on both sides. That's just the tendon from one of your medial hamstrings. Yeah, so that's it. It's definitely more common. ACL injuries are more common in females. Part of this has to do with what's called the Q angle, which females have wider hips. Looked at that with the pelvis structures, right? And that leads to a little bit sharp or a little bit larger angle coming from the hips to the knees. That's called the Q angle, which just tends to make valgus happen a little bit more commonly. There's other reasons as well, like the hamstring to quad ratio, the effects of estrogen on tendons and ligaments. Ligaments are softened a little bit by estrogen, so certain times in the menstrual cycle it can make those ligaments more likely to be sprained. Other reasons as well, but those are some of the common ones. MCL sprains are also very common, and that's pretty much due to that just direct valgus. And most of the time, that doesn't need surgery; those just heal on their own for the most part. Yeah, Olivia. Yeah, so there definitely are people that can live without an ACL. Yeah, if you want to keep playing a sport that you're playing, then you really need to get it repaired. But yeah, there are definitely certain people that can be fine without their ACL, and they just kind of rely on their muscles and other structures to hold the joint stable. But for the most part, if you want to be active and do any kind of cutting or jumping type activities, you probably want to get it repaired. Yeah. Mm-hmm. Other questions on that? Go ahead. It's kind of just like deep in your knee. Yeah, and maybe someone who's had one could tell us where they felt the pain. I think we had a couple people that tore their ACL in here, right? Nobody? Oh, wow. We usually have a couple. Yeah, that's pretty rare. Yeah, but it's really just kind of this like deep knee pain, and it results in swelling of the knee too. So that just kind of leads to overall discomfort of the knee and stiffness. But it is kind of this deep one, and this is one that you tend to hear a pretty audible pop, and definitely the person feels it themselves. But sometimes people next to them can hear the pop too, because it's a big, thick ligament, and it just pops right there in the middle. Yeah. Okay. All right. Oops. Back here. Okay, let's do this one here real quick. Oops. Did it let you send an answer? It's not. Yeah, it's kind of frozen on me too. Here we go. Try it now. Sorry. All right, a few more people there. Go ahead and send it in. Yeah, I think that's everybody. Okay, so most of you are saying A. Okay, so the ACL prevents tibia from sliding anteriorly on the femur, whereas the PCL prevents the tibia from sliding posteriorly on the femur. Yeah, so the PCL prevents the tibia from sliding posteriorly on the femur. Good. Okay. Yeah, we can go ahead and stop there, and we'll just start out with the ankle stuff beginning of class on Friday. Okay. All right. See you guys then. Have a good lab tomorrow. All right, see you. Sorry, I threw that on you last second, but hopefully you're all right with that. Okay, all right. All right, see you, Florence. Have a good one, Zach. See ya. Bye-bye.